Okay, Dr. Shadi. Everyone, give a big round of applause to Dr. Shadi Ireifej, please. Thank you. Perfect timing.
Perfect.
Thank you, thank you.
Thank you, my man.
You're welcome. All right, have a magical day. I'll be at Disney.
Okay, crush it, save
Thank
lives.
you, thank you. Oh boy.
So you've been practicing. Good.
Oh
Say
boy.
Ireifej with that.
How appropriate in the lunch.
Yeah.
Look at my
We all
size.
feel like
Every once
this.
in a while, keep an eye on me. I start going on you right now.
We'll jump on that. We'll take care of you. So thanks, everybody. So yeah, GDV. Let's talk about it. Once again, for those of you who don't know, I'm Dr. Shadi Ireifej. I'm a boarded surgeon. Graduated from Cornell in 2006. Did my internship at Angel in Boston. From there, I did 2 surgery internships and my surgical residency at Long Island Veterinary Specialist. And after that, pretty much moved out west, wanted better weather. Practiced in Las Vegas, then Silicon Valley, then LA, and now I own Vet Triage, and I'm doing that pretty much full time. So we're going to talk about GDV. The preceding notes that you'll eventually get from this talk are very, very detailed, much more than we're going to go over here. I want to keep this kind of clinical and practical. Any questions you have, anything, just throw them out there anytime. So we're going to go over the prevalence, we'll go over risk factors, etiology, pathogenesis, and a lot of this stuff, anybody in practice has seen a GDV, but we'll just review stuff. Clinical signs, diagnostics, stabilizing them, treatment, and then outcome from there. So, the prevalence from 2.5 to 7.5 for every 1,000 dogs admitted to a hospital have a GDV, very common. Males are slightly overrepresented, but I'm not sure I've ever noticed really a difference in the genders. They tend to be middle age, but any dog, obviously the larger breeds, and here are some of the common ones, but any deep-chested large breed or extra large breed dog is going to get them. I have seen the rare medium and small breed dogs that have gotten a GDV, and we can always touch on that if you're interested, but by far, of course, they're usually large breed dogs. There's a whole bunch of risk factors. I mean, there's like 50 that are published in the literature, going from really common, serious stuff to really dumb things that they just found association with, but it doesn't really amount to anything. But the older dogs, they're large breed, of course. If they've had a low number of meals per day, more anxious or stressful, fractious temperament, as opposed to the happy-go-lucky dog, they tend to be more predisposed to GDV. Family history we know about, there's definitely a genetic component to it. A history of either splenic torsion or splenectomy, it may increase the chances of a GDV. So the papers range from a 3 to 8% prevalence rate, thinking about almost 5 times risk of a GDV if you had a history of splenectomy. Again, in my experience, I have not really seen this, but it's reported. History of having a gastric foreign body increases the risk, and maybe being sexually attacked, both male and female. But there's a variety of other predisposing factors. Yes?
So at the time of the splenectomy, would you recommend doing a stomach tag if they're not already tagged?
So a prophylactic gastropexy?
Yeah.
So the question is, if you're performing a splenectomy, would you recommend performing a prophylactic gastropexy at the same time? Maybe. So so the reason why I say maybe is because as a surgeon myself, I'm relatively against doing procedures on a pet that are somewhat elective if it's an emergency surgery. So if it's a splenectomy that's like a hemoabdomen, hemodynamically unstable, and you're trying to get through surgery as quickly as possible, I'm not even going to offer it to the client because it's going to add 10-15 minutes for that patient if it goes really smoothly and you have a patient that's critical and there for another reason. I'd rather take care of this issue and then pexy them later if warranted. But because we've had, for example, I've seen surgeons who, while they're doing a hemoabdomen or a GDV, they're also neutering the dog too. And I'm like, is that really, there's pros and cons, right? But that's my take on it. But if it's a stable splenectomy, it's a mass you found incidentally, dog is stable, yeah, sure, I see nothing wrong with it. Just by virtue of the fact that those dogs tend to be the same signalment as GDVs anyway, you might as well offer it to the client and see what they want to do. So I'd be down for it in that type of context. I wouldn't necessarily be doing it based on these studies because these studies can be fairly weak, but just from that signalment is the reason why I'd be doing it. So what happens first? The bloat or the volvulus? We don't really know, but You need to have both, obviously, to have a GDV. Your standard gastric bloat, where they just got into a bag of dog food or got into the cat litter, where there's no volvulus, tends not to be a medical emergency per se, or at least not a surgical emergency anyway, because your standard bloat is not. But a GDV requires both things, and obviously most of the situations we're going to see them be acute GDVs, right? I have seen chronic ones where I call them chronic bloaters, where they tours and detours and tours again. These are the GDVs that walk in, I'm convinced, that walk in, descended stomach, completely stable. They came in for the abdomen distension and not anything else. There's no vomiting, no retching. And you take a radiograph and it's a GDV, and they're just standing there stable. Just put a GDV. I'm convinced that these dogs tours and detours themselves. I have no valid papers to prove that. That's just my own experience with them. I've even had dogs intraoperatively while I detours them start to re-rotate again, like basically undo my detorsion, because something about the motility affects these dogs greatly. Yes?
I've seen them untwist multiple times when you're going to take the two view rats and
Yeah.
take your other view.
Yeah, so she's saying during collecting radiographs to diagnose the condition, they made tours and untours just from switching views on the radiograph table. So yeah, so I'm convinced these dogs are kind of like chronic bloaters. They have sort of intermittent chronic GI signs, and they're not your classic acute GDV that come in like in shock and hemodynamically unstable. They're just stable dogs, and they just tours and detours. Yes?
If you have a dog that maybe is doing that, and maybe you have a chronic thing, or maybe visually see on x-rays, and just say decompress him, or he's fine. You just don't say, hey, we need to tack him down.
Yeah, so the question is, in that scenario where they're toursing and detoursing, but you decompress them and then they seem fine afterwards, would you still recommend surgery? Yes. Yes, I would. If they follow the same signalment. If this is a small breed dog or medium breed dog that's doing this, which again is very, very uncommon, I'm looking for a primary cause as to why this is happening. But yes, I would still recommend it, because just from your standard GDVs, we know the recurrence rate is really, really high if you don't cut them at some point. So yeah, I would still cut. Having said that, however, those cases may be the kind of cases that I actually would probably add on to my gastropexy biopsies. A liver, lymph node, small intestine, pancreas, because I'm maybe looking for something underlying here, and not just your standard sort of idiopathic GDV. Maybe they've got underlying inflammatory bowel disease or lymphoma or something that you can find. So those might be ones I actually biopsy other organs. So is it a primary condition versus idiopathic? Is it secondary to something else? I've seen dogs that come in for a GDV that also have laryngeal paralysis. I've seen them with primary lung mass, a liver mass. Did those things set up the stage for this dog to, for some reason, accumulate gas or fluid in their stomach and then tours? Or are these two separate incidences? And I'm not sure that all these cases are really idiopathic. It seems we investigate further in these older dogs that get GDVs. There may be something there that you can sort of maybe possibly blame on causing a GDV. I don't know. Lactate is always a popular topic. We're not going to go through all the different studies and numbers. There's a ton of them, but just know that lactate concentrations over 6 millimoles per liter. And again, I don't know if everybody's machines measures it with this, but to diagnose gastric necrosis with this cutoff as a marker, 88% specific, 60% sensitive. And the reason why lactate is such a popular topic is because maybe if it provides enough prognostic information for the client, and you say, the lactate is so high, you may be in the realm of gastric necrosis, which we know these dogs have a tougher time recovering post-op / don't make it. Do you still want to pursue the surgery? Because these are emergency surgeries, they're going to be thousands of dollars, and they're older dogs, and so how much weight you want to put in biomarkers like this, up to you, but there's a lot of studies on lactate and other biomarkers. The average rotation we see in surgery is 180 to 270 degrees. For what that's worth to you, and this is your classic GDV, that's what it looks like. So when it happens, you initially get hypertension. This is hypertension of the portal system, the caudal vena cava, the intra-abdominal pressure. Pressures go up because of the space occupying lesion of the GDV. So caudal vena cava compression, you end up hitting the splenectomy vasculature to the intestines, and so bacterial translocation is a problem. Portal vein compression then occurs, and that's when you end up hitting the liver. And of course, once the liver immune defenses go down, then you're again additionally prone to bacteremia. The pancreas blood supply gets hit, the pancreatitis, stomach, what we find in surgery in terms of necrosis or gastric infarcts, 10 to 37%. The spleen frequently will follow the stomach with the torsion. May or may not be engorged, may or may not be ruptured, but the splenic involvement, and then eventually over time, minutes, hours, coronary flow gets impacted, and 40 to 70% of these dogs have arrhythmias of many kinds, the most common being ventricular, of course. But this is pretty much the order of events, really simplified to what happens to these dogs and why they end up coming to us in a state of shock. Clinical signs: distended abdomen, large breed dog, non-productive retching, drooling, acute onset usually. The famous double bubble sign or Popeye's arm or reverse C, that's what you're looking for the GDVs. If you haven't seen it in like a VD view in a radiograph, there it is. This is depicting where air accumulation occurs in the abdomen for pneumoperitoneum. So if you do have a GDV with the gastric perforation, then this is what you're looking for air to tell you there might be a pneumoperitoneum here. I don't know what the cause of this dog's pneumoperitoneum is, but let's say that's the case, it's a gastric rupture. You may lose the GDV now because now the air is leaving. So it's tricky, but this is just to remind you when you take these radiographs, look at this area here, and that's typically what you find. You see that the diaphragm is outlined because the air is silhouetting. So without going into too much detail, unless you have specific questions about stabilization, it's your standard stabilization you would perform for any dog in shock, whether it's a hemoabdomen or a GDV. Fluid resuscitation, hemodynamic stabilization, 2 large bore catheters, gastric decompression. I think there was at least one paper that I know of that looked at whether or not trocherizing these dogs is of use, and it gave a positive thumbs up on it. Has anybody here performed trocherization for these dogs? Yeah. So I haven't myself, but also again I'm a surgeon, so usually when I'm coming in I'm cutting, so it doesn't, but I have had emergency doctors do this, and it seems to be successful. I have a hard time believing that a large dog with that much gas would be satisfied by this, but apparently it works. There must be so much intragastric pressure that it just seems to help. But obviously the goal is not just to decompress, of course. You want to detours and then pexy. So here is what we would typically would do to perform the gastric decompression. So you measure approximately where the last rib is, or wherever the stomach is going to be, and then if the dog is really like in a comatose state, you may be able to decompress them without any sedation or anesthesia. Those dogs are really, really ill, so you put a roll of tape in the mouth and pass the tube through that, and that way they do start to wake up more. They don't bite down. But otherwise, you're gonna sedate them, knock them out, and try to decompress them. I've only seen one dog where the tube went through the stomach when you're decompressing. I mean, the stomach has to already be pretty badly compromised to do that. So I actually don't even really measure them, because whatever, the chances of that happening are so low. And if it does happen, it's not because I bulldoze through there. The stomach is already compromised. So, but you're just trying to get it deep enough to where you get all the fluid and gas to come out. Yes, question.
With esophageal torsion, do you find it hard at all, or is it just not torsion enough?
With esophageal torsion, do you find this difficult? Yeah, so the reason why I've had issues with passing a tube, whether it be pre-op or intra-op, is because the esophagus, there's a certain level of tightness to it when you have a torsion that you just can't seem to get through. So yeah, so we place a lot of lube on the tubes, and then sort of gentle moving forward, moving caudally towards the stomach, and also a gentle twisting motion in the hopes that you can get through that distal esophageal sphincter. Now, whether you're trying to accomplish this successfully and then turn them over, shaving in the OR, or whether you're doing this in the OR, kind of depends. So I mean, I had such a well-trained team. We were so efficient. A lot of times, if I showed up, ER doctor stopped with the decompression, shave them, get them in the OR, and then we'll decompress them in the OR along with my help too. So if you're in surgery and you're having that problem, you can try to pass the tube while the surgeon is trying to detour the stomach, and the combination of those two things, you'll be successful. Yes?
If you're trying to stabilize prior to transport to an ER, like let's
what do you like to provide a little bit of sedation with to be able to do this? What drugs?
If they're at the point where like you almost don't need drugs, probably just propofol to effect would be it. I'm a bit out of touch when it comes to what's that new one again? Alfaxin. Yeah, I don't know about that one, whether that's a good replacement for it or not. But propofol to effect, and then from there, once you have the decompression that you want, then you can go ahead and onboard with your pre-meds if you want to, some hydromorphone and Valium or whatever your cocktail of choices, and then isoflurane from there.
Thank you.
Yeah.
Quickly on the gastric necrosis, maybe one, the pneumoperitoneum. Is that something, see that, bad prognosis?
Yeah, so the question is, how do you prognose these dogs if they have pneumoperitoneum and gastric necrosis? So I'll go through it later on as well, but in the obvious answer is it's going to be worse. How much worse depends. So I have yet to have a partial gastrectomy that has done really well after surgery. If they do survive the surgery, it's nowhere near as quickly as your routine GDV without gastric necrosis. I mean, it is rough on those dogs, and I have not found a good way yet. I've done the involution technique, and I've done resection, and I can't see a difference, and these dogs really have a tough time recovering.
Any resection, really.
Yeah, the prognosis goes down from there. Now, if I set the client up appropriately before surgery, and I have them agree to, if the stomach is necrosed, I do what I got to do as a surgeon to make the best choice. Great. If the owner wants a call intra-op, sure. Or if we didn't talk about it pre-op because I didn't admit the dog or whatever, then I may call them in surgery and say, hey, this is the surgeon. I'm in surgery right now with your dog. Here's what I found. Here's what it means. What do you want me to do? Am I resecting? Am I waking up and euthanizing? Am I, what do you want me to do? And go through that over the phone in the OR, like on speakerphone, and go through it with them. So, yeah, but it's a marked difference in recovery with gastric necrosis, at least in my hands. Yeah. So surgery, standard GDV. Here's a congested spleen. Here's a stomach with a multifocal, patches of discoloration. Here's a stomach with a pretty focal patch, and you see how it's kind of like sort of pooching out. So in cases where, and here's a fairly healthy looking stomach, other than of course the GDV. So if the gastric necrosis is there, what I'll frequently will do, detours them, perform the PEXI, and then if needed a splenectomy, depending on what the spleen looks like, and then go back and look at the stomach again and see, give the stomach some time to maybe revascularize. It's just like performing like a foreign body surgery. You're not sure about intestinal resection anastomosis. Sometimes if you wait a little bit, the color will clear up, and then you can make a better decision. And if it means that I don't have to perform a gastrectomy on that patient, great. So by the time the gastropexy is complete, that's 15 minutes, 20 minutes, maybe longer if you're not experienced with them. And then you look at the stomach again and see, okay, did the color change or not? So up to you, but that's how I've been dealing with these. I'll do everything else first, then go back to the stomach and look and make sure that area that's questionable is still questionable. This is a bit concerning because once you start losing the thickness of the stomach wall and you get that pouching, I'm not sure this will come back. But something like this, sometimes these things do come back when it's multifocal like this. Obviously, this is probably irreparable. You can't remove that much stomach or involute it. So this may be a death sentence. But I bet you, if you were to PEXI this and then look again 15, 20 minutes later, it may actually improve. So I'd recommend waiting. The spleen is a bit different, because you'll go into some of these cases and there'll be a hemoabdomen because of rupture of the smaller vessels. But is it a hemoabdomen that's all it is? And if you just detours and then wait, the bleeding will stop? Or is this like from a splenic fracture or something? And you have to just look in surgery and see. There are definitely cases of splenic congestion where I was like, boy, I really don't want to remove the spleen, but it's so huge and congested and it's not really changing. I don't know if there's a thrombosis in those splenic vessels or not. And so I can err on the side of caution and I remove the spleen. It's going to be a judgment call at that point, whether or not the spleen should be removed. In that scenario, if the spleen is black, obviously, or if the vessels are all ruptured for the spleen, sure. Or if you actually see a thrombus, sure. Those are obvious cases. But a lot of times you'll end up with just a spleen that was torsed with the stomach. Sorry, not a splenic torsion, but it went along with the stomach. It's untorsed, but it went with the stomach, and it's just congested and large. So I don't know. It's a judgment call there. So there's a variety of different gastropexies you could perform for these dogs, and the notes that I'll have for you will go into detail as far as the pros and cons of each type of gastropexy. The most common one, of course, is the incisional gastropexy. That's the one that most of us are going to perform. That's actually the only one that I've ever performed is that one. I've never done any of the other ones. They're just not that commonly done. But you have different ways of trying to create flaps, either 2 flaps or 1 flap, and attach that to the abdominal wall. You can try and isolate a portion either of the abdominal muscle and then have a loop of stomach go through that muscle to stabilize it, or you can isolate your rib and then use that as your pexy site. So those are other ways. You can attach the stomach to the linea, you can attach the stomach to the colon. There's a variety of different methods you can perform. I've only done the one because that's what works and it makes the most sense to me. But there are studies on all this stuff showing how strong they are and how long they tend to take to heal as well. So there are many options for it. And then also, not necessarily in the case of GDV, but in a prophylactic gastropexy, which is where you probably would perform that at the time of the spay or the neuter for the right breed dog. Laparoscopic is an option for these cases, and I perform maybe 2 of these, and not on my own. I don't have an interest in it, and again, as a surgeon, I really don't see prophylactic gastropexy that much, So, but this is it's a beautiful looking gastropexy there with using a scope. So this is all in the surgery books here. The adhesion length, you're looking for somewhere between 2.5 and 5 centimeter in length for that adhesion from the stomach to the abdominal wall. It should be located at roughly 6 centimeters oral to the pylorus. So the incision to the abdominal wall should be 2.5 to 5 centimeters. A matching incision in the stomach, and this is 6 centimeters away from the pylorus, and then you suture those 2 openings together. This incision in the stomach is not full thickness. It's just the superficial layer there. In the abdominal wall, same thing. You pretty much in the abdominal wall, you're looking for the fibers underneath, and that's how you know you're deep enough. And then you suture the 2. And mean surgical time using with this surgery, with incisional, is about 70 minutes, about an hour. But if you do this a lot, you're looking at 30 minutes of surgery time with these cases. And so then when you do suture, well, how many people here perform gastropexies? Yeah, okay. So what I found to work, and again, depends if you have an assistant or not. I tend to get spoiled. I have an assistant usually, but you don't need one, obviously. And I'm usually using a size 0. Usually I'm using Proline for these. I know surgeons that use PDS as well. Fine. Doesn't matter, but it doesn't matter. Whatever. You just need the adhesion to stay there long enough for it to heal. 2 weeks, 10 to 14 days. And then suturing, usually the deep portion, I'll suture first for the gastropexy, and I'm starting deep in the abdominal cavities towards the liver, and then I'm moving caudally, and that's the deep portion, and that's the first suture line. And then the second suture line will be again deep abdomen but closer to me, right? So the one at the side of the incision that's closer to you, and then from cranial to caudal, starting from where the liver would be, let's say here, and then you're moving caudally along the rest of the incision there, and that's your second layer. And I found it to be the easiest. If you start, with the easier portion, which is the part of the incision that's closer to you, now you have to deal with the deeper one, and it's unnecessary difficulty there. The picture is bad, but what I was trying to show here is the abdominal wall, especially if you're alone with doing a pexy. You can take a towel clamp and attach it to the abdominal wall and hold that up. And so with one hand you have the towel clamp, and your other hand is suturing, And so you can have it just right to where that's it. It's where you don't have an assistant. So usually on ER, again called in for emergency, I have anesthesia tech, and then just me in the OR scrubbed in. And they can scrub in too if they need to, but the towel clamp, hold the abdominal wall up, and then you can start suturing with the other hand. And that also works too. The problem with using Balfours with the self-retracting Balfour retractors is that it's going to create tension for your site. So where you think you're going to move the stomach to the abdominal wall, you're now creating a tension to you, which is going to be annoying to fight against. And then also it may loosen up your end game once you perform your pexy, and then you remove the retractors. Now the suture that was nice and tight has now loosened. So that obviously defeats the whole purpose. So I tend not to use Balfours for these. I have the towel clamp up, or an intern or resident or somebody, but towel clamp, and if I'm doing it alone, and then start suturing.
Did you say what size suture you like to use? Like,
Yeah, size suture 0 is what I'm using. Yeah, zero proline is what I typically go with. Yeah.
Have you heard of a study where you don't take the doctor into surgery, put them on a lidocaine CRI and just trocarize them?
Yeah. So the question is, have you heard of a study that where you don't take them right to surgery, you have them on a lidocaine CRI and trocarize them? So I've not read the study. I also may have missed it, but I've known actually practitioners who do it that way. They will do exactly that. They'll decompress the dog, have them somewhat sedated, usually a nasogastric tube after the decompression, and basically just empty their stomach, for the next 12 hours, 24 hours, and then cut them the next day. And what they are proposing is that it basically takes the risk of gastric necrosis down, because now you let the stomach rest, and then the next day you can look at the stomach, and that's what the stomach is. So if there's still necrosis there, after doing 24 hours of decompression, sedation, and G-tube placement, then that necrosis is probably real, right? So that's the idea there, and it gives you more time to stabilize them. Yeah, certainly I would say probably at least the surgeons that I know do it how I do it. Like once you diagnose it, you're in the OR. You're trying to get it moving, but that is certainly one way of doing it. Yeah, I would say probably conversation with the client is going to be warranted in that scenario. They have to understand pros and cons of it, and of course it's going to add to the cost of it too. It'll, if that matters to them. Overall complication rate 76% with these dogs, and this probably speaks to them presenting to you in shock, right? So acute renal injury, DIC, arrhythmias, splenic thrombosis, peritonitis, and a bunch of others. I mean, all the abbreviations you can think of, these dogs are prone to, right? They're critical, and they're coming to you that way. So these are all conversations with the pet owner to explain to them that it's going to be a multi-organ involved type of disease, not just the stomach. It's everything is related to this. So any one of these things and more could be the end for this patient despite your best efforts.
So if you have an arrhythmia, does that have you say, whoa?
Yeah.
Practically, now we need to kind of make sure you correct that before you can think about anesthesia.
So the question is, if you have an arrhythmia, how did that change your anesthesia protocol? Do you proceed with surgery there? That also depends. So I'm a bit more aggressive with them. I will try and stabilize their arrhythmias using lidocaine, either a bolus and then a CRI, but get them into the OR. You could make the argument that if their arrhythmias are so bad, like they're having like VTAC or something, where they have still no pulses and all the parameters aren't good, that you may want to stabilize them further before doing so. And that gives you the opportunity to decompress them, hopefully place an NG tube and wait. Yeah, so it'll come down to your personal experience with them. I can be a bit more aggressive. I'm like, let's get them in there. But that's me. I'm sure there are lots of folks out there who would probably prefer that the heart is fine beforehand. Yeah, I'm a bit more aggressive with them because the surgery is so fast, so I just do it. But I don't know. Anyone else have a different take on that? If you had a GDV, if assuming you folks cut them, would you end up waiting if you found really bad arrhythmias beforehand?
I'm gonna be perfectly honest, I work in GP and we're not doing an ECG until the animal's hooked up to anesthesia, so we wouldn't even know.
Oh, for
I
the
mean,
ECG.
I mean, you listen to them.
Yeah. So she's saying the ECG wouldn't be hooked up to them until they're under anesthesia, yeah. But I would tend to forge ahead. Would be my, maybe it changes my conversation with the client, but I'm going to tell the client that arrhythmias are a risk regardless of whether they are currently happening or not anyway. This is sort of two things. Number one, they're older pets, so if you're able to induce them, decompress them, shave them, get them into radiology, 3-view chest rads, make sure you're not missing anything crazy there, and then go to the OR. So 3-view chest rads on your older patients, middle-aged to older patients, and then also these are older dogs, so whether you're seeing pulmonary consolidation because there's a mass there, or that's pneumonia, or it's atelectasis, maybe it's low focalized hemorrhage, whatever. But these are reasons why thoracic radiographs beforehand are pretty good for. And I have found incidental either liver mass on X-ray or a pulmonary mass on radiographs too. And that just warrants a conversation with the client. Get them on the phone again and talk to them and say, hey, we found this questionable thing and don't know what it is. And if they've had no prior respiratory symptoms and all of a sudden they have this, what is that? And yeah, it's a conversation. Is it worth enough of stabilizing that patient, waking them up, and submit these for a radiology review, and then, or maybe repeat them the next day, see if they're still the same. Maybe you're fortunate to have a CAT scan in your facility, and so you can run it through a scanner. There's options, depending on what the client wants, right? It all depends. Or your client's like, nope, I'm done. Whatever that is, I don't want to deal with it. I'm already $10,000 deep for a surgery that he's old, and now I got this. So it just depends on your conversation. But the point is, there's options depending on how you want to talk to the client. So the overall incidence for factors that affect mortality is a wide range. Obviously, these dogs come in all different conditions. Survival. Oh, I want to actually address one other thing too. Recurrence here. So the recurrence rate is very, very low for these dogs, and I'm not. I don't even know why it's even that high. I mean, I have not seen one come back. I've seen them develop gastric bloat, just gastric distension, but not torsion because I've PEXed them already. And so what I tell clients is, the risk of recurrence is higher if they have comorbidities. If this is a cushingoid animal, it's got diabetes, if it already has thyroid disease, if it has cancer from something else, anything that's debilitating to them is going to inhibit their healing. Maybe there's a chance that my PEXI would break down, and that would be it. So otherwise, I'm not really sure. About the recurrence. It's just another reason why also I use Prolene, at least I know that suture is there forever. So there's that. But anyway, I wanted to comment on the recurrence part. Survival, wide range. With no surgery, 80% are going to die, right? So even if you decompress them, and the chance that they're probably going to come back, they already have a proclivity towards torsing. So, and just like all the other factors with GDVs, it's such a common disease. There are a ton of literature on the different prognostic factors. So I'm just only mentioning a few here. How they present to you. If they're showing up to you in obtundant or comatose, then there's a high risk of them having issues with the procedure. If they need a splenectomy, 40% are more likely to have complications with that. I would say that's probably true. I definitely see more blood transfusions needed and more cardiac arrhythmias post-op with a splenectomy, with the GDV, than without a splenectomy. So for sure, it sets them back. I don't think it's nowhere near as bad as gastric necrosis. Necrosis is a major issue with these dogs, for sure. But again, ideally you can leave the spleen in there. But if you can't justify it, then out with it goes. And by the way, if I do remove the spleen, I am submitting it for a biopsy, assuming the client can afford it, of course. And I do also collect a liver biopsy at the same time. Just staging purposes. It doesn't add that much time-wise to the procedure itself. As long as the client, finances aren't an issue for them, then I'm going to submit the spleen if I do remove it, and I'm going to get a liver biopsy in these cases as well. Lactate, the presenting lactate, what percent change in lactate, what the lactate is after surgery, whatever, all these things are factors. There's a ton of literature on this, and I have all in the proceeding notes for you guys so you can look at it at your own convenience. There's a ton of lactate stuff, and a lot of other biomarkers too that may or may not be clinically relevant, but these are all ways of trying to figure out prognosis for these dogs.
Quick question.
Yes.
Splenectomies, even if you're just doing the mass removal, you know why they get BPCs? Or family correlation?
Yeah. So why do these dogs get BPCs? The thought is that there's after you detors them, let's say, oxidative injury is a problem. Reperfusion injury is a big thought process there. That's why lidocaine is so good, because it helps with scavenging oxygen radicals. So that's one aspect to it. Another aspect to it is various hormones that that spleen, liver, heart will release that also will affect the heart as well. I can't remember the names, it's mostly academic, but anyway, so there's that. And then any level of shock, regardless of the cause, whether it's cardiogenic shock or whatever else, will make them predisposed to arrhythmias
Just
too.
regular splenectomy from a mass and no GDV.
Oh, yeah, so what causes the heart arrhythmias with a routine splenectomy, not a GDV? Yeah, so I still see arrhythmias with splenectomies as well. It's not as common if it's your elective procedure. I think a lot of those cases, if they're stable otherwise, why would you have a heart arrhythmia with just a routine splenectomy, no other issues? I think something to do with manipulating the tissue. Maybe a problem with these dogs. I don't know otherwise what causes it. Yeah, everybody focuses their studies on the critical patients, and so oxidative stress is a big one, and chemical and hormonal release. But yeah, I don't know why your routine splenectomy would have arrhythmias, but I have definitely seen that in my own hands as well. I think it's something to do with manipulating the spleen, the vascular structure. I don't know, maybe with splenic contraction. I don't know. Yeah. But I definitely.
Like, hey, whatever you're doing to it.
Yeah, I mean, clearly, because they weren't there beforehand, and now they're there afterwards. They
You're just doing
don't.
blood vessels, so it's not like, I mean, you're handling it, but it's not like it's traumatic.
Right.
per se, so,
Yeah. The vessel ligation is should be, you know, it should be pretty smooth. And I don't know, but yeah, we definitely see it. We definitely see it. You also wonder if it is, you know, anecdotally, I would say I have a higher rate of complications after a routine splenectomy for a splenic mass when it comes back as malignant. I definitely see a rougher recovery and more complications with malignant splenic tumors than benign. I think there's something there about whatever hormones the cancer is releasing that'll, you know, kind of like a paraneoplastic syndrome that's causing arrhythmias. I think there is a difference there. That's my own evidence. That's my own experience. There's no evidence to back that up. Key points: prevention is ideal. So if you're a GP and you have the option of performing a prophylactic gastropexy at the time of spaying and neutering, great, go for it. Obviously, acute GDVs are way more common than chronic ones. I do believe we need more studies on whether or not there's actually a primary cause of GDVs. I bet you if we looked hard enough, we could find a reason for the GDV, or at least a presumptive reason. I mentioned the towel clamp usage if you're the only one in surgery. Delay gastric resection until you're done with the pexy, and then look at the stomach and see if it's still questionable. I mentioned submitting spleen. If I do remove the spleen, biopsy it, I always get a liver biopsy for these dogs. And then, my opinion on concurrent surgical procedures. I wouldn't do them myself if they're elective. I would just focus on the emergency part and then tell the owners, hey, when this dog is through this problem, we should then remove that mammary gland tumor or neuter him or whatever, Yes?
I know you said you haven't done many, but the laparoscopic, do you feel like that's more beneficial than just like your traditional?
Yeah, so what are my thoughts on laparoscopic prophylactic gastropexy? So the studies show that these dogs have way more mobility and a faster recovery time with laparoscopic than your conventional, midline ciliotomy. From our point of view, it takes so long to set up with a laparoscopic tower and get everything together, and the amount of people you need to perform a procedure that's going to, after you set it all up, then you have to do the laparoscopic thing, and if you're not really great at it, it becomes a frustrating thing. So there's a learning curve to it, right? But from the patient standpoint, yeah, the studies all show laparoscopy has a quicker recovery for these dogs. When they attach, what do you call them, accelerometers to these dogs to look at mobility, like an objective measure of mobility, they are moving around way sooner and way at a much higher degree than with a ventral midline incision with scoping procedures. So yeah, from an analgesic standpoint or recovery standpoint, well worth it. Yeah. Yes?
Are you offering gastropexy using like foreign body and atlas trees?
Yeah, so do you offer a gastropexy to perform like a foreign body or what have you for atlas? Yeah, so I tend not to, but I do know surgeons that do that. And I don't know if there's a right or wrong to it. If you're going to do that, you want to perform the clean procedure before the dirty one. So before you remove that foreign body, pexy them then, and then remove the foreign body, right?
Do you feel like maybe doing that complicates their post-op recovery?
Doing the prophylactic gastropexy with it? No, I don't think so. Yeah, it's more anesthesia time, but that's about it. If they're otherwise stable, like if you feel that the patient can handle more anesthesia, even if it's only 20 or 30 minutes more for the pexy, I don't think it would affect their recovery time. Yeah. But the times that I've done like an intestinal foreign body surgery along with a prophylactic gastropexy, usually the client is asking me about it. And I'm like, oh, okay, sure, yeah, we can do that if you want to, I always tell them it's at my discretion. If the patient is doing well under anesthesia, I'll do it. I have the right to say we're not doing the pexy. Let's just do this because he's having blood pressure issues.
I feel like coworkers kind of are back and forth on it. So I'm like, do I do this with every golden?
Yeah.
Take it out of stock?
Yeah. I don't know the answer to that. It's a tough one. At minimum, I would reserve the right to cancel the pexy in surgery if you deem it appropriate in the best interest of the patient. But otherwise, are you obligated to? I mean, I don't think so. But I don't know if others have a different opinion on that. Yeah.
That's a good one. Look at the Great Danes. I mean, obviously they're trying to recommend maybe neutering spay, maybe older, orthopedically, with knees and stuff. If you do it at 6 months in a pexy, anything as they're growing a lot larger, is that gonna move it at
Yeah.
all, or anything where you should
Yeah,
do it when they're young?
the question is, if you perform a prophylactic gastropexy on a large or giant breed dog when they're young and they still have more growth to do, is that going to ruin your pexy site? And I don't think so, but I also don't know. I also don't know the answer to it. You know? Yeah. I mean, when in my years of writing this talk and looking up the literature, I haven't seen anything on that yet. Theoretically, once you create an adhesion like that, that should be permanent, and the rest of the body will just adapt to whatever. But I don't see that as being a problem. But I don't know. There's no studies on it from what I've found. It wouldn't stop me from recommending prophylactic gastropexy. I would still do it. But yeah, I don't think that.
It's not movement, I guess.
Yeah, I would still do it. Is my contact information if anybody wants to get a hold of me. Otherwise, any other questions regarding GDP or anything else? Yes.
Do you, when you do your surgeries, do you do pre-intraoperative antibiotics or not?
So the question is, do you do preoperative or perioperative antibiotics? I always, yes. They're gonna get cefazolin at time of induction, and what is it, every hour or something? My techs do this, but yeah. Sorry. So every and then once they are awake, they're gonna get IV cefazolin every 8 hours until they can take oral, and then they're on oral cephalexin, and then they go home with that 10 to 14 days. Now, yeah, the antibiotic usage has changed, so this is what I've done. Nowadays, they're recommending much shorter course antibiotics. And on the human side, they've been doing that, right? Where it's a clean procedure, you're on antibiotics for like a day or two or something like that. It's like very short-lived. So I don't know what the current standards are for antibiotic usage with a procedure that has no contamination otherwise. I would say that if you have, if you suspect a dog that's coming in for GDV and they are at risk for bacterial translocation because they have so much ileus and everything is just hyperemic in surgery, you worry about bacterial translocation, I would put them on antibiotics for those dogs. Whether it be only cefazolin or cephalexin or something a bit more broad spectrum, up to you. But in that case, I would. I'd be so worried that they already are older when they get into surgery, so they already have a poor immune system. Then now they're compromised with shock, and then the intestines, the liver, all that stuff. So, but if it's a fairly stable, run-of-the-mill procedure or it's prophylactic, your call. But yeah, mine are going to get antibiotics perioperatively and then post-op. Yeah. Keep in mind also too, I practiced for a long time in Long Island. So those New Yorkers, man, they're, anything goes wrong. So, they expect 2 weeks antibiotics. And so it's a problem because you're trying to balance good medicine with, concerned pet owners, shall we say. So I don't know if there's but as long as you're backed up by the literature, you do whatever you want, as long as the standards are there to back up. Yes?
You would still get like a standard course of NSAIDs afterwards,
So question about NSAID use. I actually have never used NSAIDs for gastrointestinal surgery, regardless of whether I'm entering the viscera or not. I've never used NSAIDs for these. Now, if they go home and they're having maybe incisional like inflammation or cellulitis or something like that, then I would start. If they're eating, drinking, otherwise fine, then sure I would. But it is not part of my protocol. If they're going to go home, when they go home with analgesics, they're going to get tramadol or gabapentin or both, depending on the pet. I'm not sending them home on NSAIDs. I was surprised when I saw surgeons sending gastrotomies and enterotomies home with NSAIDs. I didn't even think that was a thing. That COX inhibition could be a problem for gastric mucosal protection, but people are using it, they're doing it, and but I don't. Yeah, I don't. Yes.
So what do you use perioperatively then?
For analgesics?
Yeah.
Opioids.
Okay.
Yeah. Hydromorphone typically what we use. I'm very conscientious of older pets being just knocked off their butts on opioids, so I will underdose first. I'll start low, and you can always work your way up. I don't want to have a large old dog recovering from major surgery sitting there recumbent because he's knocked out on narcotics, and that's when they're prone to getting pulmonary thromboembolism and pneumonia. So I want them up and moving. At the end of the day, a spay is a midline incision. How aggressive are you with those analgesics with spays? So to me, their discomfort must be equal to spay, maybe a bit more. But after a day or two, I want them off pain meds, and usually by then they're ready to go home if they're stable and all that stuff, eating and going. Another point I wanted to make regarding arrhythmias actually for postoperative care for oral meds. So procainamide, I think it's on the slide there, I had procainamide, here it is. So I never really use it injectable unless I had an internist there with me to tell me to do this. But otherwise, I'm using lidocaine. But procainamide orally, if they have arrhythmias, at any point during my hospitalization stay, I typically do send them home with like 10 to 14 days worth. And now it may be a bit overkill, but if I've seen arrhythmias in the hospital, typically those arrhythmias are intermittent. They come and go, right? And you don't have the opportunity to have necessarily a Holter monitor at home for these dogs to see what arrhythmias they have. And knowing that arrhythmia can turn into something way worse very quickly, I tend to have them on 10 to 14 days of procainamide, basically until the recheck. And then at the recheck, I check an ECG, make myself feel better, no arrhythmias, and then we're done. Now that 2-minute thing of ECG doesn't reflect 24/7, right? But at some point you have to decide to stop. So I don't know what the answer is for that. If they are not having arrhythmias in the hospital at all, obviously they're not going to go home on any meds. If they are having arrhythmias, well, how bad does it have to be for you to treat them at home as well? I don't know. Typically on our end, when I look at arrhythmias, I'm thinking if their ECG length, whatever that is, has 30% or more VPCs, and or the patient is clinical for arrhythmias, so maybe it's not 30%, it's less, but they have dropped pulses or they're showing occasional pale mucous membranes or weakness, then I'm going to treat them more aggressively with antiarrhythmias orally when they go home, and then recheck the ECG at the first recheck. I don't know if that's the answer or not, and it's very difficult to monitor ECGs in a hospital setting, let alone at home, right? We're fortunate that we would have 24/7 ECG monitors on them, right? You may not have ECGs like that in your practice, and you certainly don't have it at home. So I don't know what the answer is for those cases. So I think be a bit more aggressive because I want to at least try to cover all my bases. If that dog all of a sudden has a lethal arrhythmia at home, and I didn't cover it, and there was evidence of arrhythmias at the hospital, boy, should I have done that? Then it sucks. It's a tough one. Anyway, I wanted to address the arrhythmia thing. Any other questions? Okay, thank you very much. Thanks for all the questions. Thank you. Hey.